said, this is not something new. This is just us updating the guideline and to make sure that we answer any questions that you have. You might have by now seen this floating around. I mean, those of you have been in the hospital from before, this is pretty much the assessment tool or the classification tool that we trialed last year. The problem with our current classification and current practice is that we perform using physiology, but then when we come to actual practice, we try and classify according to a different set of guidelines or classifications. The reason being is that once we introduced STAN was based on the FIGO guidelines, hence we needed to use those guidelines as we were using STAN. But then there was a discrepancy between, okay, well, we're using physiology and now we're using FIGO. Which classification should we put at the end of this? Okay, similarly, anybody who's coming from another trust that uses NICE guidelines, for instance. So we're using physiology, but I'm used to the NICE classification, and we're all starting to get mixed up about the wording or the language that we're using when we're describing fetal monitoring. Okay. Just to make this very, very clear, as I said, this is something that you already know, we've already introduced, you would have had this at your induction, but we're going through it step by step again to make sure that we've answered all questions and any unclarities that you may have. So this is the classification table. And obviously you would have also seen the Fosnac-Frugal trees that we use in association with STAN. Let's start by breaking it down. So there are four main categories in the table. The first one is the chronic hypoxia / chorioamnitis. Yeah, and this is basically, we're trying to figure out the babies that are not actually fit for labor. So a baby that is not responding from the beginning, from the moment we actually lay eyes on this trace, this baby is not responding, it's not behaving normally. We think that this baby has pre-existing brain damage or is in the process of getting pre-existing brain damage. We should not be putting this baby into further stress or any hypoxia. And this baby we should be considering delivering this baby as soon as possible with the fastest, least interventive way if we can. As in, if she's almost fully dilated and she's about to push the baby out, fine, but otherwise we would usually err on the side of a cesarean section, just for safety of this baby. It's also very, very clear that we need to make sure that we tell mom that we don't know what the status of the baby is at this point. This baby is not telling us enough whether it's well or not. What we can see is that this baby is not engaging, this baby is not responding. Some of the babies will be born in good condition, although they can't we still can say it can't tolerate labor, but it hasn't been stressed out enough. Some of those babies can be born in poor condition because it's been stressed out and it's, again, not telling us how it's doing. Does that make sense? Because that's a very difficult conversation to be having and can be confusing when we're not certain how to counsel the mothers or the couples. Does that make sense?
Yes.
Yes, that's not a very certain yes.
It is yes, like I can only say for myself, like I'm not sure if we all have to say.
Okay. The other baby is the baby that we're suspecting chorioamnitis with. So the baby that comes in with the high baseline, everything else seems to be fine, but the baseline seems to be quite high for this baby's gestation or for this baby's previous CTGs. And usually there's risk factors that are also associated with or risk factors for infection. Okay. Once again, this baby is not, we should not be pushing this baby further. We should have a clear conversation with the mom saying, well, your baby seems to be developing an infection. Babies don't do very well with infection, etc., etc. And that this is actually a different pathway from the hypoxia. That's a different pathway from the monitoring. We actually need to deliver this baby sooner rather than later to be able to give the baby the treatment that it requires, which is the antibiotics. in order to try and help with reaching this point, there is an initial CTG assessment tool. Now, there are stickers flying around on labor ward. Okay, we are just trialing them. None of this is set in stone. This is basically out there for trial and error and for feedback to see what do we think, is this making life easier, or is it just overcomplicating things and it's another additional sticker? In which case, we will literally just be taking it away. But the whole point is always thinking about signs of chronic hypoxia and chorioamnitis. So when we're assessing a trace, we always look at the baseline, whether the baseline is appropriate for gestational age and for this baby. We're confirming that there's normal variability and that there's cycling. And if she's not in advanced labor, then there usually are accelerations. If these are not, if we're not ticking all these boxes, it may be that we are, or we probably have chronic hypoxia or chorioamnitis in the mix. Okay. So don't be confused about the sticker. If the sticker is not there, this is what you need to be thinking about. Is the baseline appropriate? Variability and cycling, accelerations present, late or shallow decelerations not absent. Yeah. And then as we're starting labor, we just need to make sure that this baby is happy to go ahead. Okay. So that's the first category, the category that is not really fit for labor. Mukta, you're about to say something?
Yes, I have a question. Is there a book or any paper where we can read exactly the range of the normal baseline for each gestation? Because I'm not very sure that as we increase in our training years, we have a very clear, we can't say that, okay, for preterms, what is the lower
There are two big
baseline
trials. So there are two big trials that looked at the gestational age and the heart rate over gestation age. One was a German study that covered about 80,000 babies, and another was an older English study that covered about 30,000. Okay, there it does give you a description and a curve that's available there. However, the best tool, because again, we like it to be more specific. We try and personalize our care. The best way to assess your baby is to look at what the baby's heartbeats were, a heart rate was in the previous assessments. That is your best indicator. Okay, if you don't have a previous CTG, look at the antenatal clinic appointments. There's always recorded numbers there. It will tell you where this baby's heart rate was when there was nothing else happening during or earlier on in pregnancy, and where to expect it now that this baby is older and now that's actually going through a stress.
That's true, but recently I've been finding in the assessment unit that few patients haven't had any subsequent clinical FHR recording because initially they haven't done it in early stages, and then if she had subsequent scans at every visit, for some reason they have not, they've just written scanned and they have not listened into the FHR. So only thing what has happened is that when she's coming in to DAU, that is the first time you're recording and she's 37, 38 weeks and you don't have really a comparison to make.
Okay, so we talked about that several times in the past, about even if somebody's had a scan, please try and figure out their heart, try and listen into the heartbeat to get the rate, because the scan is not going to tell you the heart rate. The scan is going to tell you that they've seen the heart beating. And that's a big missed opportunity. If there's nothing to compare to, unfortunately, you're stuck with the big population curves, which obviously is not, yes, it may be helpful, but not necessarily as specific and as sensitive as the actual baby's heart rate recording.
Are we able to send a message to the midwives? Because obviously midwives are listening in before you see the patient. And
most patients have a heart rate recording in clinic most of the time. I mean, the fact that you're seeing somebody who's 38 weeks who's not had any heart rate recordings is actually quite shocking, but I'm also assuming that's probably very, very rare. But yes, to all of us, so it's not just the midwives, we also do antenatal clinics. So whenever we are in the clinic, let's always try and get a heart rate, please. it can save a baby's life and brain. Yeah?
Yeah.
So are we all clear on chronic hypoxia and chorioamnitis so far? As I said, we're not really saying anything significantly new. Okay. Once we've deemed that this baby is fit for labor, you're now starting to follow the hypoxia pathways. Yeah. The backbone of hypoxia is generally the gradually evolving hypoxia. So we start off with the group that is either showing no hypoxia at all, okay, in which case the baby's baseline will be the same. The baby will spending enough time at the baseline, okay, variability will be within normal, it will keep on cycling, and there won't be any decelerations. Or the baby that has started some cord compressions or some hypoxic events are occurring. However, the baby is well compensated, is spending enough time to recover at the baseline, variability is still fine, okay, and is still possibly able to cycle still. Again, this is normal in labor. I would not classify that as normal when it's an antenatal trace, but as long as it's in labor and we're monitoring, okay, this is normal. And in this situation, the baby is telling you that it's fine. The fact that it's decelerating is telling you that it's fine, that it's able to respond, that it's aware of what's going on, and that there is absolutely fine in between the decelerations. Okay, that is normal. With that, you actually don't need to have any further clarification. Basically, if you have any other test, like an ST event is happening, you don't need that. You're going to ignore that. Okay. As long as the baseline is stable, variability is normal, and the time spent is appropriate, so more than 50%, the risk of hypoxia is low. Does that make sense? Guys, are you still there?
Yes.
Am I still making sense?
Yes, because I'm only answering, that's why I kept quiet.
Okay. Now, the other important thing that we need to also be mindful of is that we like decelerations. Yes? Remember we said that at the beginning, I actually like decelerations a lot more than accelerations. We like seeing decelerations. As long as they're not too much and they're not too prolonged, we actually like decelerations because it tells you what this baby is capable of doing in stressful situations. But if things progress and the baby is starting to get to a decompensation phase, okay, or this baby is spending very little time to recover, so it's going into subacute hypoxia, that is the time when we actually need to make the baby happier, and we need to pay very good attention to our additional test, which is the stand monitoring. Okay, now if you read the description for the gradually evolving hypoxia with signs of decompensation, it is going to start from just the rise in baseline. And the issue is that from the edge of compensation, which is once the adrenaline has been released, to the point of brain ischemia, there are no more signs on the trace. The trace is not going to give you anything else. You have seen a rise in baseline, and the next step is you're going to start seeing brain decompensation. What's happening in between, you can't assess. There's no more signs for you. Okay, how soon, how fast do we need to intervene? How much do we need to do? Well, that's where Stan comes in. That's where Stan helps us. Okay, so if you start seeing that the baby's baseline is going up, we've reached that point. We're starting an adrenaline response. Okay, we need to make sure that we have Stan that is working properly and that is telling us how this baby's heart is doing. Okay, ideally, we don't want Stan to alarm. So if we have seen the changes happening, we want to actually make this baby happier while we still have the time. Obviously, if Stan starts alarming, then we need to make this baby happier much, much sooner. And if we can't do that, then we definitely need to deliver this baby. Okay. Does that make sense? Great.
Thanks.
Thank you.
Just one question. On the protocol there, it says no cycling. It's a term I hear used quite a lot. Can you just define cycling just before going any further? Is that okay?
Okay, so cycling is basically the change between the sleep states, as in when baby is, so baby is either going into sleep and wake rhythms, okay? As long as baby can still go through that cycling phase, that means that baby is happy. That means baby is chilled out enough to actually go through a sleep phase and then wake up, carry on, and then go back to sleep. So that's a very, very good sign. But as you could see at the beginning, once the babies start feeling more and more decelerations and more stress, cycling can go away. But when we're talking about loss of cycling, that means that baby is not going through the sleep-wake cycles. Now, that means that baby is stuck in one of the phases. It's either completely asleep or completely awake, okay? We don't like completely asleep, because if baby's being stressed and it's suddenly completely asleep, that means that baby is really unwell. While if baby is cycling, so it's always completely awake, that is, okay, not the best event. You are stimulating the baby, but it means that baby is still fine. Does that make sense?
Yes, thanks.
So if you start seeing that baby is alternating between low variability and then better variability with accelerations and then low variability again, and that's a baby that's going sleeping and waking up, sleeping and waking up. If the baby is continuously having a normal or increased variability, so not increased as in not more than 25, but good variability between 5 and 25 all the time, it seems to be accelerating all the time, it seems to be decelerating all the time, that baby is continuously awake. That baby is being stimulated all the time, okay? Which is still fine. Baby is still responding. It just can't fall asleep because of what's going on. But if baby suddenly goes completely flat, that's not a good sign. That means that baby's brain is now becoming ischemic, okay? And that actually takes us to the third stage, which is a pre-terminal, as in the baby is completely flat, possibly with shallow decelerations or getting prolonged decelerations. In which situation, we're not going to be asking for any additional tests. We can see that baby is really unwell and is in immediate danger. And that baby needs immediate delivery to improve its condition. Okay. So these are the basic 4 categories of the trace. One that was not fit for labor. The second, which was normal, so the baby that's not getting any hypoxic events or is compensating very well for hypoxia. The third was the baby that gets a bit of hypoxia, okay, and is now starting to go into decompensation or is happening too frequently and is going into subacute hypoxia, or the acutely hypoxic baby, in which case we just need to deliver that baby. Okay. Once again, another sticker. These are not written in stone. So the important thing about this is the way we're thinking. We are still describing the CTG in the Dr. C. Bravado manner, okay? So we always need to find an indication. We always need to look at the baseline, okay? We're gonna assess the baseline, whether that is appropriate for this baby and gestational age, and whether the baby is spending enough time at the baseline. Variability, you're gonna look at the variability and see whether it's within the normal range, as in 5 to 25, and is there still cycling, okay? Are there any accelerations? We're talking about early labor. Yeah, accelerations is fine, and that's a good thing, but it's not necessarily important as labor progresses, okay? Decelerations, are there any decelerations? So yes or no, okay? And if there are decelerations, are they slower to recover? So are they baroreceptor or chemoreceptor? Is it taking longer for the baby to recover from the deceleration, or is the baby literally just bouncing back the moment that the contraction is done, okay? And remember, we had already assessed at the baseline stage whether the baby is spending enough time at the baseline. Because if baby is not, then we're bordering subacute hypoxia. We always need to think about where the baseline started at the beginning of the trace, which is why on the sticker, as I said, the one we're trialing, we're trying to just write up here. So it's basically a number that you will be copying from sticker to sticker to make sure that you pick up any change in baseline. Regardless of the sticker, the things that you need to be asking yourself, is the baseline still the same or is it rising? Has it risen more than 10%? Okay. Is the baby spending enough time in between contractions? Is the baby still cycling? Is the baby's variability normal? So has it gone less than 5 persistently, or is it more than 25, which means that baby's panicking? Okay, or are we seeing something like a sinusoidal pattern? Okay, so are there any features of hypoxia? And if that's so, what is the type of hypoxia? And the important question is, are the central organs well oxygenated? Okay, so as in, is the baby's brain okay? Is the baby's brain showing a flat variability or a panic mode? Okay, and then you make a management plan. Always make sure if there's any other risk factors. Once again, this is just a sticker that we're trialing. This is not something, I mean, those of us who've done obstetrics for more than 6 months, they would have seen many, many stickers come and go. Okay, it doesn't even take long for stickers to change. This is just something that we're putting out there for your feedback. Okay, regardless of whether there's a sticker or not, then you need to make sure that this is how you're thinking. Now, it is also okay not to be able to figure out what the assessment is. However, if you can't figure out what the classification is for this baby, then you need to let someone know. You need to escalate. Okay. If you can't classify where the baby's CTG is, actually anything outside the green, you need to let the team know. Okay. Anything outside the green, the midwife in the room needs to inform the obstetric team and the coordinator, which means that if there is any rise in baseline, you will have to be informed. And that is what the policy or our policy is saying and the guidelines are saying. You need to make sure that you are aware, and you want to be aware because that's your chance to act or intervene to make baby better. Okay. Obviously, if there is any acute hypoxia or preterminal trace, you will know the alarm will be going off. Does that make sense? Are we still following?
Yes.
Yep.
Okay. So you've also seen on the back of the information card, there's also the fast and frugal trees. Okay, so this is basically the assessment tool when we're going through or when we're starting to use STAN. When we start the STAN recording, we need to look in within the first 40 minutes and make a decision whether this baby is appropriate to use STAN. No, sorry, it's appropriate to use STAN for this baby. We start off by making sure that it is appropriate, as in that this baby is more than 36 weeks. Okay, and obviously the baby has to have ruptured membranes because STAN works with a fetal scalp electrode. STAN should only be started in the first stage or passive second stage. Do we know why? Guys, are you still there?
Because the baby is not distressed at the time, more likely, and is going to determine the baseline of the fetal well-being, cardiac well-being.
Yeah, yes, because this machine is now going to take the baby's status that you're starting at as the baseline. So for whatever changes that happen. So if you're starting with a baby that's already stressed, or you're starting with a baby that is deteriorating really fast, then you won't be able to assess the baby using STAN. And you'll be falsely reassured by the fact that the STAN is not alarming. Okay, so it has to be started in the first stage when baby's happy. Okay, and we should make sure that there's no contraindications for applying a fetal scalp electrode to start with. Okay, so there's no risk of infections, there's no risk of bleeding from this baby. Okay, before we actually start putting the clip on. Okay, we're going to ask ourselves the simple questions. So have we fulfilled the initial criteria? Yes. Is the baby's baseline appropriate at this point in time? If yes, carry on. If not, obviously, then we can't. So if the baseline is appropriate, then we can proceed. If it's not appropriate, then we need to think about infection or chronic hypoxia. If the baby is spending more than 50% of the time in decelerations, okay, that means that baby's already in subacute hypoxia. You can't start STAN assessment when baby's already hypoxic. And if the baby is not showing any normal variability or is not actually cycling properly, then again, you can't start. So you have to start STAN on a non-hypoxic baby at a stable stage. Okay. If it is, then you can proceed with STAN. If it isn't, then you can't use STAN for reassurance. Okay. Once STAN is on, you need to assess the trace every hour to see whether STAN is still suitable. So is your quality of the signal still normal? Okay. And remember, we said we don't want STAN to be alarming. Mukta, do you have a question? You've raised your hand.
Yes, I just wanted to cross-check how many crosses are needed for the signal, like the right signal in the STAN.
So the idea is that you need to have at least one check per minute. So one cross per minute. If you have gaps within the monitoring, okay, you can't be reassured because the machine is not checking. Okay. Now you have to understand that the STAN machine does not alarm if you have a one abnormal cross.
Yeah.
The minimum alarm happens when there is at least 4 minutes of abnormal baseline or abnormal ratios. Okay. So if you have a cross that is happening once every 5 minutes, then the reality is that you can have problems that are lasting for the 4 minutes and you have no STAN alarms. Okay.
Yeah, because I was like, that's what I was saying to the, like on my nights, but they said no, if you need minimum 3 in each box, sometimes 5.
No, the normal is so somebody or a baby that has a heart rate of 120, you would get across every 30 beats, which means you would usually get 4. Okay. Somebody who has a heart rate of 150, you would probably be getting 5. You don't have to have 100% for STAN to be appropriate. You need at least one cross per minute.
Okay.
Okay. And you should not be getting gaps of more than 4 minutes apart. If you're getting more than 4 minutes apart, that means that STAN might not be reliable.
Okay. Thank you.
Okay. So remember, what we just said is that we are trying to make sure that this baby is fine. We're not assessing to make STAN happy or to make a CTG trace look nice. We are making sure that this baby is fine. So what we're trying to do is we're trying to get this baby through safely, and we're trying to avoid reaching the point where STAN starts alarming. So if you're assessing the trace and you can see that the baby is spending less than 50% of the time at the baseline, even if the baby is not alarming, and even if the baby's baseline is still the same and the baby's STAN is not alarming, okay, you still need to reduce the contractions because yes, baby is fine at this point in time, but we still have a way to go. We should not be pushing this baby to the edge. Okay. If you're noticing that variability is becoming abnormal, as in the baby is panicking or the baby is getting flat, going flat, even if STAN is not alarming, we need to make this baby happier before STAN alarms. Okay. This was what I was saying at the beginning. If you have a rise in baseline, it means that the baby is starting to release adrenaline. STAN might not be alarming at this point in time, but you need to make sure that the baby is happy to cope and we don't trigger a STAN alarm. So we try and make this baby happier. And obviously, when there is a rise in baseline, you also need to think about, is there any chance of infection? Or is this hypoxia? Why is the baseline going up? Any rise in baseline, you always need to think about it and justify why this is happening. Does that make sense?
Yeah.
Okay. If along the way anything is triggering a review, then that's a reason to escalate and have further discussions. Okay. If there is a problem with the quality of STAN, so you're noticing that you're not getting enough crosses, or you're noticing that you're not getting any crosses at all, okay, then you may still carry on. So ideally, I would think about changing the clip or changing the skin tag, okay, to see whether I can get a better quality signal. But if I can't improve the quality signal, then you have to rely upon physiology, which is what we're relying upon anyway, but you now lost the safety of STAN. Now, if you get a STAN event, remember, if the trace is normal or if the baby is already compensating, then we don't need to be alarmed at all by any STAN events, okay? Because STAN here is not required. Even if it alarms, that is not something that you need to be concerned about. So you can actually ignore it and continue observing. Just check that the quality is fine and that the STAN monitor is picking up properly, okay, and that the skin electrode is on appropriately. Because if there is some bad connection, sometimes you can start getting biphasic events just because the T waves can become abnormal shaped just from the poor connection. But if you're noticing that we are within the amber box, so the baby is spending less than 50% of time at the baseline, or the baby's baseline is raised, or that there's abnormal variability on the trace, that means that you need to improve the baby's quality very soon. And if you can't do that, then you need to deliver this baby. Does that make sense?
Yes.
Yeah.
Okay. Does anyone have any questions?